Welcome everyone to this evening's program entitled The Nexplanon Contraception, the Evolution of LARCs in Canada. It's very exciting to be able to talk about a new option for contraception that's now available for Canadian women. So I'd like to start by recognizing tonight's sponsors, so the Society of Obstetricians and Gynecologists of Canada, as well as Merck Canada, for helping us to put on this program this evening. Now, just as a disclaimer, we want you to be aware that any information is provided for scientific purposes only, and it shouldn't be construed as a recommendation for use of any of the products or indications. And please refer to the appropriate product monograph for approved indications. And we will identify when we speak about unapproved use of a product, and just so that you are aware, SOGC and Merck do not support product discussion that's not consistent with approved prescribing information in the official product monograph. So I'd like to start by introducing our speakers for this evening. So I'll start with myself. I'm Dr. Amanda Black, and I'm a professor of obstetrics and gynecology at the University of Ottawa, and I hold a research chair in women's health at the University of Ottawa as well, and I'm also on the board of directors of the Society of Obstetricians and Gynecologists of Canada. And I am joined this evening by a contraception guru from the United States, Dr. Mitchell Crennan. And Dr. Crennan is a tenured professor and director of family planning in the Department of Obstetrics and Gynecology at the University of California, Davis. He's a former chair of that department. He did complete his residency in obstetrics and gynecology at the University of California, San Francisco, followed by fellowships in family planning and clinical research, epidemiology, and biostatistics. He's received research funding from the NIH, USAID, WHO, CDC, private foundations, and industry. He's authored more than 300 peer-reviewed papers, review articles, book chapters, and books related to family planning and contraception, and most recently the 6th edition of Spiro Frondarni's Clinical Guide to Contraception. Dr. Crennan is a past president of the Society of Family Planning, and he's currently a deputy editor for the Journal of Contraception. So we're thrilled to have him here with us this evening because he's going to give us some insight into some of the real-world experience. So welcome.
Thank you, Amanda. Welcome to everybody that's joined us.
So just before we go any further, I just wanted to give our disclosure slides so that you're aware that we have done some advisory board work, consultation, and received honorarium, as well as some grant or research support for the companies listed in this disclosure slide. So, what are our objectives for this evening? Well, we want to start by reviewing the contraception landscape in Canada and the evolving role of long-acting reversible contraceptives. We're going to discuss the clinical profile for the Elonogestrel subdermal implant, which in Canada is known as Nexplanon, and best practices for incorporating the implant into clinical practice. And then lastly, to share strategies for counseling patients on the use of the Elonogestrel subdermal implant, including real-world experience from the United States. So just to give you an idea of what it's going to look like this evening in the agenda, you can see we have about an hour set aside for the actual presentation, and then we've set aside 25 minutes for audience question and answer at the end of the session. So you will have plenty of time and opportunities to ask questions and to get insight into that real world experience in the United States. So as far as how to ask a question, like I said, the Q&A session will follow the presentation, and what we'll get you to do is to type your question into the Q&A box that appears on screen. So you can see that it appears at the bottom of your screen. And the questions may be submitted at any time throughout the broadcast. We'll answer them at the end, but certainly feel free to submit them at any time throughout the broadcast. So let's start by looking at the evolving contraception landscape in Canada and the role of long-acting reversible contraceptives, otherwise known as LARCs. So I thought we'd just kind of have a quick look at what's happened over the years in Canada, and going back about 60 years ago, that was when the first birth control pill was approved for use in Canada. And interestingly, that was actually before birth control was decriminalized in Canada. But we could see not a lot happened up until the Norplant 6-rod implant was approved in 1994. We did have condoms female condoms in 1996, the injectable progestins in 1997. And then in 2000, there's kind of a big change for the contraception landscape when we had the introduction of the Elonogestrel IUS 20, which for those of you who aren't familiar with that term would be the Mirena. And at that time, the only one we'd had was the Novity copper IUD, so the copper IUD 200. We then had a patch come onto the scene, a vaginal ring a couple of years after that, and then the extended regimen oral contraception in 2007, which now might seem like kind of old hat, but back then it was kind of more of a newer thing. Then in 2011, we started to see more and more copper IUDs come onto the market and be available. And we also saw the addition of the Elonogestrel IUS 8 in 2015 and the Elonogestrel IUS 12 in 2017. And now in 2020, we see the introduction of the Elonogestrel subdermal implant to the Canadian marketplace. So what are we using in Canada for contraception, and how are we doing, and do we actually need anything new? Well, what's interesting is we did a study in Canada and we looked at women who are sexually active and not trying to conceive and determined whether or not they were using a method of contraception. And what's interesting, of those women, 15% actually never used a method of contraception. 20% of them were using a method of contraception inconsistently. So what does that mean? Well, that means that we may end up with unintended pregnancies. And we know that in Canada, 40% of all pregnancies are in fact unintended. We also know that in Canada, for every 100 live births, there are 31 induced abortions. So there are 330,000 live births for every 100,000 induced abortions. So clearly, we can probably do much better than this. So what are women in Canada using as their method of contraception? And when we did a survey in 2016 looking at this, we found that the most commonly used methods of contraception were condoms, followed by oral contraceptives, and then withdrawal was actually the third most commonly used method of contraception. And long-acting reversible contraceptives, which at the time were mainly intrauterine contraceptives, were used by a much smaller percentage of Canadian women. So what we can see that in Canada, less effective methods of contraception appear to have a higher usage rate than long-acting reversible contraceptives. And we know that unintended pregnancies are associated with a cost. And we did a study a few years ago where we tried to determine, well, what exactly is the direct cost and how much money could we save if we looked at increasing the use of long-acting reversible contraceptives. And when we did that, we determined that there were over 180,000 unintended pregnancies per year in Canada, which result in $320 million in direct healthcare costs. So that's direct costs. That's not all the additional society costs or individual costs. And the total cost of unintended pregnancies that was due to imperfect contraceptive adherence in that was $220 million. So if we just did a conservative switch of 10% of users switching from oral contraceptives to an intrauterine contraceptive, because that was the only one we had available at the time, we found that would result in fewer unintended pregnancies and $35 million could be saved annually, even when taking into account the cost of the contraceptive. So those sort of things have led our Canadian societies, such as the SOGC and the Canadian Pediatric Society, to publish statements saying that LARCs are the most effective method of reversible contraception, and they should be considered as first-line options for Canadian women and Canadian youth. So how can we expand what options we have available in Canada? Well, certainly it would be nice to have more estrogen-free options because some women aren't able to use estrogen. And what about long-acting reversible contraceptives that you don't necessarily have to place in the uterus? And we need to increase our options in Canada compared to the global landscape. So for example, the Elonogestrel subdermal implant is available in 110 countries. And it is now available in Canada. It was approved in May 2020 by Health Canada, and pharmacies are now carrying that. So the concept of a contraceptive implant is not new. So if we go back several years, I mentioned Norplant, and that was the first implant, and that was a 6-rod implant that was effective for up to 5 years, and it was removed from the Canadian market in 2000. Jadel is a 2-rod system that's available in some countries. It's good for up to 5 years. And then there's also the Sino implant, which is available in some countries, and it's a 2-rod implant that's available, that's effective for up to 4 years. Now, the Elonogestrel implants, the first one was Implanon, and that was launched in 1999. And the successors for that were Implanon NXT and Nexplanon, which is the Elonogestrel implant that will be available in Canada. So I thought we would go through a little bit just about the overview of the Elonogestrel implant, just to give you a bit of background on that. So what exactly is it? It's a single rod implant. It's about 4 centimeters long and 2 millimeters wide. It's progestin only, so it does not contain any estrogen, and it comes preloaded in a sterile disposable applicator. And you think, what is Elonogestrel? Have I ever heard of that? Well, in fact, Elonogestrel is the active metabolite of desogestrel, and you have heard of desogestrel because desogestrel is the progestin that's in some of the oral contraceptive pills that we currently have available in Canada, including Marvelon. It's approved for up to 3 years of use, and it is radio-opaque. The Nexplanon is radio-opaque, and so that means it can be localized by X-ray, by CT scan, and it can also be seen on ultrasound or MRI. So what does it contain? Well, the core of it contains an ethylene vinyl acetate flexible copolymer. So it's non-latex, it's BPA-free. It does contain some barium, and that's what makes it radio-opaque, as well as a bit of magnesium stearate. And it has a rate-controlling membrane that's 100% EVA as well. And it comes in this preloaded sterile applicator, which is single-use and disposable. And one of the differences, and Dr. Crennan will talk about this, is the fact that it's a single hand as opposed to needing 2 hands to do the application. The implant's inserted under the skin, so subdermally on the inner aspect of the non-dominant arm. And if you're going to be marking it out, you'd be marking it 8 to 10 centimeters from the medial epicondyle up towards the shoulder, and then 3 to 5 centimeters below the sulcus. And after it's inserted, it's palpable by both the healthcare provider and by the patient. So how does it work? Well, it mainly works primarily by inhibition of ovulation. And the Elonogestrel is rapidly absorbed after insertion. And in fact, ovulation inhibiting concentrations are reached within 1 day. And maximum concentrations are observed within 2 weeks. And the Elonogestrel may inhibit ovulation within 24 hours. So according to the pharmacokinetics, we talk about the rule of threes, and what we see is that the Elonogestrel levels peak and then they decrease gradually. So you see that peak at 3 days, and then you see it kind of come to more of a steady state at 3 weeks, and then you see kind of where it's going to be by the time you hit 3 months. And it's good for, and it's effective for up to at least 3 years. After the implant's removed, the Elonogestrel levels drop rapidly, and they're actually undetectable within a week. So ovulation resumes within 2 to 4 weeks for most women, and pregnancies have occurred as soon as 7 to 14 days after removal. So if someone has it removed and they don't want to get pregnant, then they should start using a method of contraception right away. How well does it work? Well, there were no pregnancies in clinical trials of up to 3 years duration. So that in those clinical trials, the Pearl Index was 0. And this included over 900 subjects in over 23,000 cycles with over 1,800 women years of exposure. Now, if we compare the effectiveness to other long-acting methods of reversible contraception and permanent methods of contraception, we can see that it fares very well. Of course, all of the long-acting reversible contraceptives and as well the permanent methods of contraception have failure rates of less than 1%, but certainly the Elonogestrel implant fares very well in comparison to all those other methods. Now, what type of side effects can someone expect with these? And it'll be helpful again to have someone from the US who has more experience with this clinically and in clinical practice. But what the studies have shown that first off, there are unpredictable changes in the bleeding patterns. But there can be some other side effects as well, which may or may not be completely attributable to the implant. And that would include headaches, weight gain, acne, breast pain, emotional lability, abdominal pain, or ovarian cysts. Now, what about bleeding patterns? Because we know that like other hormonal contraceptives, the Elonogestrel implant can result in changes in bleeding patterns. And for most women, bleeding is actually reduced. So over half have no bleeding or minimal bleeding. However, almost 18% did experience prolonged bleeding and 6.7% experienced frequent bleeding. But really the key take-home point from this is the fact that over half of women have no bleeding or they have infrequent bleeding. Now, what about what happens with their bleeding over time? Because you want to be able to counsel patients on this. And what we see from the studies is that most women who start off having favorable bleeding patterns during the initial reference period have favorable bleeding patterns through the first year, so between 80 to 84%. And then women who have early unfavorable bleeding patterns, between 37 to 51% of them will experience improvement into favorable bleeding patterns through that first year. Now, what about weight? Because women, of course, are always concerned about the potential effect that hormonal contraceptive can have in weight. And in U.S. clinical trials, the mean weight gain was about 1.3 kilograms after 1 year and 1.7 kilograms after 2 years, but there was no comparator group, so the amount of weight gain attributable to implant use versus other factors is really unknown. Now, for context, a comparator group was included in a single-center study conducted in an adolescent medicine clinic, and what they found was weight gain was similar for implant users and controls. So there was no significant difference between the two groups. Now, sometimes people can have side effects, but maybe those side effects aren't bad enough that they will discontinue it. So it's really important to know is what sort of reasons would people have for discontinuing their method of contraception. And in clinical trials, what they found that bleeding irregularities was the most commonly cited reason for discontinuing the implant as their method of contraception. And the second most common was planning pregnancy. Now, 13.9% also discontinued for any adverse event. And in those adverse events, that included things such as emotional lability or weight increase, headache, acne, or depression. Now, does it have an effect on bone mineral density? Because sometimes if we are concerned about potential effects, especially given our experience with the injectable progestins. And in fact, when they did studies, they found that BMD changes at 2 years between the Elonogestrel implant users versus non-hormonal IUC users. There was really no significant difference between the two groups. Estradiol levels were not completely suppressed, and mean estradiol concentrations remained above the levels seen in the early follicular phase. So the key takeaway was this, is that during implant use, estradiol levels appear to be maintained at sufficient levels for bone health. Now, does it have any non-contraceptive benefits? Because certainly that's one of the things we look at when we're counseling patients on their methods of contraception. Well, it has been shown to be associated with reduced pain with endometriosis. There does appear to be an increase in bleeding, but we certainly don't see the amenorrhea rates with it that we do with, for example, the levonorgestrel IUS 20. And the bleeding patterns can be unpredictable. However, we do see a decrease in dysmenorrhea, and in one study, 77% of those with baseline dysmenorrhea reported a resolution. Can there be complications of insertion or removal? Yes, but we can see that those percentages of low for complications of either the insertion or the removal, and I believe Dr. Crennan's going to talk to us a little bit more about what sort of things we can look for at the time of insertion or removal and how we could potentially avoid any of those complications. And that leads me to Dr. Crennan to talk to us a little bit more about the real world use and experience with the Nexplanon, some of the lessons that you've learned over the years from having this available in the United States. Dr. Crennan, I'm going to hand it over to you.
All right. Well, Amanda, thank you. And I love the questions that are coming in. And I think what you'll see is that some of the information that has already been reviewed, we're going to go over again. And I think whenever you see something that's really important to understand, that's why we're going to go over it again, and I think it'll help explain even some of the questions, and then the rest we'll get to during the question and answer session. But keep them coming; they're great questions. So, as Amanda already went over, there's more than 20 years of clinical experience. The implant first became available in 1998 in Indonesia, and we've had it in the U.S. since 2006. Originally as Implanon, with a two-handed inserter, and more recently as Nexplanon with a one-handed inserter where the implant also has barium sulfate. And the importance of the barium, as was alluded to earlier, is for localization, we can easily do an X-ray, whereas for Implanon, you can't do an X-ray because there's no barium present. So we're going to go over a little bit about the well, the main benefits are the high efficacy, and I want to go over more about understanding those bleeding patterns, because that's really, really important to take away if you're going to be able to counsel your patients about what to expect. And then insertion and removal issues. So let's start out a little bit about timing. When can you put this in? Well, the reality is anytime you're comfortable that the patient isn't pregnant, doing a pregnancy test by itself is never enough. You have to talk to the patient and find out a little more information, because obviously it takes about 9 to 10 days from the time of unprotected intercourse for a pregnancy test to turn positive. So in the United States, the CDC has these 6 criteria where if the patient meets any one of these criteria, then you can be really assured that she's not pregnant or potentially in early pregnancy at the time that you are placing the implant. And all these are available through the CDC website. But talking to the patient, as well as potentially if you feel more comfortable doing a pregnancy test, is the most important thing. So when can you start it in relation to other contraceptives? If you take out the IUD or take out an implant, you can put an implant in at the same time without really a need for backup. If somebody's currently active on Depo-Provera, you can place the implant anytime. You don't necessarily need to wait till the end, because then you know she's covered. If she's using a short-acting method or a non-hormonal method, then you do need backup for 7 days. And so for our patients, for example, that are using birth control pills, we'll place if it's not really towards the end of the pack, let's say she said, I just started my new pack 3 days ago, then we'll place an implant and tell her use the pack for another 7 days. If she's using a non-hormonal method, you do want to start it ideally in the first 5 days of her menstrual cycle. If it's not during the first 5 days of her menstrual cycle, and you can be assured that you feel she's not pregnant, for example, she's mid-cycle, but she has not had sex since her menses, you can go ahead and place it, but tell her that she still needs to use a backup method for another 7 days. So if you can't keep it all straight or don't remember, the easy thing is it's always easiest just to say, use a backup for 7 days, but otherwise there is a little delineation. And then obviously post-pregnancy, what's great about the implant is it's easy to place immediately or postpartum or during that hospitalization. There's lots of research to show there's no impact on breastfeeding. There's negligible excretion in breast milk. It's very safe to use. So in the United States, it's common for the implant to be placed in the hospital prior to discharge. And then after an abortion or a pregnancy loss, it can be placed immediately. And I think in those categories, there's sometimes even more questions. So let's just break it down to surgical abortion and medical abortion. Obviously, with a surgical abortion, it can be placed right after the procedure. If the patient is receiving sedation, then you do need consent. And actually, for those of you that provide abortion or uterine aspiration services for miscarriage, the patient wants an implant, it's just easiest to do all your consents ahead of time. If you're actively using a blood pressure cuff during your procedure, so she's getting sedation, so you're using a blood pressure cuff, then it's might be helpful to make sure the blood pressure cuff goes on the opposite arm of the one you're intending to place the implant, just to make things go smoothly. And then also think about what the room is set up like, that you don't want to have it set up really well to do your procedure, but then go up to her arm and realize that there's a lot of machinery or other equipment around that makes it hard to position her arm. And I do have a lot of colleagues that will sometimes just place the implant in the recovery area rather than in the procedure room, just because they can position the patient better. You have to figure out what works best in your facility or in your office if you're doing that. But the important thing is it can be done really at the same time. And then for medical abortion patients, there's research to show that placing the implant on the day the patient gets the mifepristone does not decrease efficacy or increase continuing pregnancy rates. Unlike Depo-Provera, which we recommend not to use at the same time if possible, the implant can be placed on the day of mifepristone administration. And we know that when you do that, immediate insertion results in a higher utilization than with telling the patient she has to come back. So as far as concerns around insertion and removal, one thing is to make sure you have the correct location, and that was reviewed a little bit earlier, but I want to go through it again because it's so important. And then understanding the implications of deep implantation. This is, you may have a patient who comes to see you for removal and you can't feel the implant. You have to worry about where is it? Is it maybe under her fascia? There is only a couple of millimeters, and I want to stress that. In a very thin woman, there is only a couple of millimeters between her skin and the fascia. We don't realize how close it is when the woman is very thin. So it's very easy to place it under the fascia and actually even think that you can feel it well. So it's important to make sure that you insert correctly to minimize the likelihood of deep implantation. And very, very rarely, about 1 in a million cases, and this is really good data from France showing 1 in a million, the implant will actually be placed in or near a vessel and migrate to the lungs. And you may hear about that. It's important to know about it, but it actually is about 1 in a million. So very importantly is, how do you prevent deep implantation, since that's a grave concern? Well, one is go through correct training. So there's the company of training videos. Please watch the video. You may recognize me as doing the training. But the main thing that you can do to prevent deep implantation is get your technique correctly. The top 3 things are how you do it. So please watch the video. Make sure you understand what's important about positioning the patient, putting the needle in the right place, and then you don't run into removal problems. Well, initially, in case you come across old information, the implants, including Norplant, were recommended to be placed right over the middle of the arm, right over the bicipital sulcus. And the reason was just it was easier. It was kind of flatter there. Place it right over the middle. It's easier for the doctor, without the realization of that area, in case you go deep, is right where all the nerves and vessels are. So there wasn't any revision. Keep in mind that this implant was first introduced in the world in 1998. So there wasn't any revision of that for almost 20 years, where the recommendations were changed by the company just saying avoid the sulcus, no further guidance of where to go. And I find that a lot of people like to go over the biceps, rarely over the triceps. And the reality is that it's easier to access the biceps. But it wasn't until about a year and a half later that really important recommendations came out to go over the triceps, as Dr. Black went over earlier, about 3 to 5 centimeters posterior to the sulcus. And so you can see this is where Implanon was originally recommended to be placed, right over the area where the vessels are. And you know what? If you were placing it correctly and you were in the area between the dermis and the subcute, it really wouldn't matter. But nobody's 100% perfect. My wife reminds me of that all the time, so that you have to be concerned of, what if I do go too deep? What if it's somebody who is really thin and I go too deep? You're right where the nerves and vessels are. And the Nexplanon is 3 to 5 centimeters from that sulcus area for a reason, all right? And that reason is actually from these cadaver studies, which were published in 2019. So if you think about the fact that implants have been available in general for decades, it wasn't until recently that somebody took the time to say, let's really figure out what's going on in these areas as far as nerves and vessels. And in this study, the arm was checked in different compartments, and they did the same thing over the biceps, and really found that when you're in the area that's marked in red, which is 8 to 10 centimeters from the medial epicondyle, unless you're at least 3 to 5 centimeters towards the outside of the arm, you still run into nerves and blood vessels. Now, importantly, the reason you want to be 8 to 10 centimeters above the medial epicondyle is that's where the ulnar nerve becomes superficial. So don't say, oh, well, you know what, I'm going to go over the triceps, but because of the way your arm is, I think I'm going to go a little bit closer to the medial epicondyle. Don't do that. You can end up with nerve damage. That's where the ulnar nerve can be superficial. So you need to be at least 8 to 10 centimeters from the medial epicondyle, and then 3 to 5 centimeters from the sulcus, because you can run into nerves and vessels even in this superficial region. So there is a rationale as to why. Now, when it comes time to removal, even with a well-placed implant, the vast majority of removals are very straightforward. No problems. And even when providers say they have problems, they're usually problems that they can get over, that even a provider who's doing this for the first few times can get the implant out. But the ones that are really problematic are when you have difficulty finding the implant, you can't palpate it, and or the removal is difficult because you know it's deep. And there was a large prospective study in the U.S. that followed 7,300 insertions and over 5,000 removals, and asked providers to report on what they found. And what they found was that about 6 in 1,000 felt the implant was deep at insertion. And I put it in quotes because it doesn't mean it wasn't palpable, and it doesn't mean it was too deep, but that they reported it as a deep. Now, at the time of removal, about 14 out of 1,000 cases, the provider said, I had difficulty. But again, that doesn't mean the provider couldn't get it out, or even that was really what I might think of as very difficult to remove, but just that there were some difficulties, maybe a little extra scar tissue or something, but the majority were able to be removed. Only about 2.5 out of 1,000 are considered deep at removal, but that just meant the provider needed to go a little deeper than they might have originally felt they would need to based on a good a good insertion technique. But the ones that you really worry about are the non-palpable ones, where you say, God, I can't even feel where it is. I can see where the mark was, but I can't feel it. That only happens about 1 in 1,000 times. So it's not going to be something that you're going to come across commonly. But it's really important to think about, what do I do if I have that patient where I really can't feel it? And I would also add, even if you can feel it and it's really deep, if you feel that it's going to be hard for you to remove, you've got to face that same kind of question. So what do? Do you attempt blind removal? Do you just make a cut by where the implant scar was, the insertion scar was, and you just do it? Do you refer to a general surgeon, since now you're getting into the arm, and you may be a gynecologist who says, I'm not used to the arm and digging in the arm, so general surgeons are really the people to do it? Do I just leave it in and say, you know what, sorry, eventually the hormone will wear out and there's nothing we can do? What about a specialized removal center? Or do you get an x-ray and then you can make sure it's there, and then because you know it's there, you can start to dig around where you can't feel it and attempt removal? And hopefully most of you have realized that the answer is you refer to a specialized removal center. And the reason is because it may be subfascial, so don't just dig around trying to find it. It may not be there. Migration is normal, even a little bit of ways from the implant scar, but keep in the back of your mind, 1 in a million could even be in the lungs. Very often, patients where their arm is being dug around end up with a large incision, and we're going to go through what you can do if you're a specialized center. There's nerves in the area that can be damaged. We'll go through that. You're creating multiple visits, and potentially you're exposing somebody to general anesthesia that they don't need. So refer to a specialized center. I want to show you this one example that came out of my colleagues in St. Louis, where this is an implant that was subfascial and was right next to the nerve. And here you can see the implant in green with sitting right on top of a nerve in yellow. So don't just go digging for an implant. Even in a thin woman where you think you can feel it, it may end up being under the fascia and you can damage a nerve. Now, there are 2 publications that describe specialty clinic experiences, and I want to go over this with you just to reiterate why it's important to send your patients to a specialty center, and I think a little later we'll talk about what's organized in Canada for you. Now, our group in Sacramento, California, described our first experience with 51 referrals. There were 6 of them that we felt we could feel. Now, keep in mind, these patients were sent to us where the provider didn't think that she could feel the implant. We could, and we were able to remove those easily without any other examination. There were 45 we couldn't feel, and we could localize it with an ultrasound. And you can get an idea here of what we do. We kind of mark where the implant is using ultrasound, and then we can go straight down on the implant with a specialized modified vasectomy clamp and go right around the implant and pull it out. I want you to notice, if you can see in the lower part there, there's a scar, a big scar, where a general surgeon went in and just cut and said, I can find this. You can see the scar was nowhere near the implant, and this is what you want to avoid having your patients go through. So in the office, the implants that we could localize that were above the fascia, we could remove those 100% of the time in the office, and we could remove 83% of those that were below the fascia. And this one, in this case, was below the fascia, and you could see we could remove it with about a 5-millimeter incision from below the fascia. So that's why you want to have specialty centers that can do this. And then you're thinking, well, that's great in the U.S. There's a specialty center in South Africa that just reported their data, 74 cases. 6 were palpable. They removed all of them, and those were non-palpable. They were, again, able to remove all of them. They were superfascial, and most of those that were subfascial, they did make a really big incision, about 2 centimeters. So one of the keys is that they still were able to get it out without general anesthesia, but as centers become more and more experienced and more specialized, they can do even better for your patients. I will tell you, we are about to submit an update of our experience. We are now up over 90% in the office, even with subfascial. All right. So what did we learn from this experience? Well, when we looked at the patients who had non-palpable implants, interestingly, if somebody was non-obese, almost all, or when we look, I'm sorry, let me put it this way. When we look at all the subfascial implants, almost all of those patients were non-obese. right? And when we look at the superficial implants, it was about half and half. So if somebody's non-obese, you have to have a really high concern that the implant is subfascial if you can't feel it. Again, another reason not to go and just dig around. The other thing we learned is that of the patients who had non-palpable subfascial implants, about a third of them reported having an implant placed at the same time another one was removed. So again, our data wasn't strong enough to make global recommendations, but at least in our practice, we do recommend that if you have a very thin patient and she's going to have an implant removed and replaced again through the same incision, you may want to consider not using the same incision because you've lost your resistance and it's incredibly easy to go below the fascia, way easier than you may think. So it's just something for you to consider. And if you want to go through the same incision, you can, but at least be aware of how much more likely it may be that the patient may end up with an implant that's subfascial. So the whole idea here is to avoid problems by understanding the issues before you get into the situation. All right. Now, what about 3 years of use? We know that we can go longer than 3 years, and I want to go through some of this information with you. It is off-label, but it's important for you to understand the why. So if you're going to counsel your patient, and we routinely counsel our patients about leaving the implant in for longer because you're going to avoid unnecessary procedures. If you have a woman, for example, that wants to use an implant to prevent pregnancy for 5 years, why should she go through 2 procedures or 2 implants and 2 removals? That's 4 procedures when she could go through it just once potentially, right? So that if you're going through it a second time, that's another opportunity to place it subfascially, which she wouldn't need, right? So the first data that came out about extended use came out of the Choice Project in St. Louis in 2015. There was a report of 123 women who had used the implant through 4 years. The reality is that's not enough data to meet Health Canada or US FDA criteria for approval, but at least it gave the idea that maybe people could use it for longer. And they published a follow-up study a few years later where they had 291 women that used the implant all the way through 5 years, and half of those women were obese, and about 223 of them had used it for at least 4 years. And this 4 years is it's pretty close to what would be required for Health Canada or FDA criteria for approval. So at least we have more data on 4 years. Well, the reality is we have much better data on going out to 5 years. And this was a WHO randomized trial using the 2-rod levonorgestrel implant against the 1-rod etonogestrel implant. And there was a Paragard non-randomized comparator group, but you can see there was almost 1,000 women who entered the study. Importantly, most of them were non-obese, and they did a 3-year assessment and then continued on to 5 years. And what I want to point out from the study is that most women were 21 to 35, but from a BMI standpoint, very few of the initial population were obese, less than 10%. So as we talk about looking at this data to help support whether we can counsel women to use the implant for longer, we really are talking about a non-obese population when we're looking at this WHO study. And you can see in the randomized arms between the 2-rod levonorgestrel implant, which is approved for 5 years, and the 3-rod etonogestrel implant, which is approved for 3 years, that the pregnancy rates were exactly the same. There were no pregnancies in either group pretty much after the 3rd year. And you can compare that to the copper IUD, which is another highly effective LARC method, where the pregnancy rate over the 5 years was significantly higher, 10-fold higher. And that you had about 200 women completing 5 years or 60 months of use. All right. So this is really good data to tell us that this is effective through 5 years, but really only in non-obese women. So how do we address extended use in obese women? Well, the only thing we can say is we don't know, right? We do know that there is this data that 90 picograms per mil is the minimum concentration for ovulation inhibition, but we don't know what other factors occur at less than 90 picograms per mil. We know there's cervical effects. So some of this data that came out of the Choice study showed that there are the etonogestrel levels at year 3, at year 4, and in year 5 in women of all weight categories, normal weight, overweight, and obese, are about the same. In the 5-year group, first of all, there's way fewer women in the 5-year group of 50 compared to almost 150 in the year 3 and 4 group. And this concentration was significantly lower than what's seen in the earlier years. All right. So there are no national guidelines. There are organizations that make their own determinations. And my recommendation is that the clinical data is most important and that secondary outcomes are useful when the clinical data is vague. So in our practice, we recommend that the implant through 5 years in non-obese women and through 4 years in obese women. And I think the data is pretty supportive. All right. So that kind of gives you a little bit of clinical data and stuff that you can use with counseling. And I'm going to turn it back over to Dr. Black.
Great. Thanks so much. That was really helpful. And it was interesting because you talked a bit about deep insertion, but one of the questions that came in was about superficial. Do you find in clinical practice ever that sometimes people complain that it's maybe a little bit too noticeable or too superficial?
Right. And I think you want to be equally afraid of it when it's really superficial. When you're in between the dermis and the epidermis, there's a lot of nerves there. You'll see a lot of swelling, big rash, and people will complain of a lot of pain. So the key is to go through the training. The training really works well. The needle, when it goes through the skin, you can get through into the subcutaneous tissue and then just pull it back to where the bevel is just inside the skin. And the video shows that really well. And you'll know you're at the right level. If you are so scared that you're skimming the skin and you're getting really between the dermis and the epidermis, you're not doing your patient any good. So go on in. Don't be afraid to go in. You can always pull the needle back so you're not too deep. And I think that's a really key point that's even in the training video.
And I think one of the other questions that came in too, and you certainly alluded to this when you said the key to avoiding complications is technique. One of the questions was is it important to do training, or should you do training in order to insert this and remove this? And I'm gathering from what you're saying that yes, you definitely should be doing training.
Right. And I don't know the program in Canada and how they're rolling it out. There definitely are going to be videos available, same ones that we use worldwide. But definitely, I commonly, like when I talk to medical students, I always will joke that MD sometimes can mean misguided deity. You think you can do it all just because you have those letters. Don't. Go through the training. The training is great. It really puts things in perspective from technique. And I think that you can do so much good for your patient by putting it in correctly that she'll have a good experience. Because you would hate to have her need a removal because you put it too superficial, or for her to end up with a huge incision or a lot of difficulty getting it removed because you put it too deep. But it's really not hard to do if you go through training.
Great. Thanks so much. And another question, because you talked about the centers of experience in the U.S. of which you are one, and I think a lot of people were asking, well, how do we have centers of experience here in Canada, and how do we find out where they are? So just to reassure you that we are certainly, Merck Canada has worked to identify areas that would be considered centers of experience, recognizing that we certainly don't have the experience that you would have at your center right now, but just making sure that we also have the additional backup support required. So I think making sure that we have the right imaging modalities that we can access, and making sure that we have people who have done the training. Are there any other recommendations that you would have for these centers of experience? Right.
Well, I think two things. One is one of the reasons we're trying to publish our information, including videos from how we do it, so that, I mean, everybody might say, I did one or two of these and publish a video, but we are trying to do it in a regimented way and put our videos on available and publish it so that other people can learn from it. And then secondly is we all had to start somewhere too. And to be fair, a lot of the centers of experience in the United States started from people who had learned a lot from Norplant and then go on to train other people. So all the fellows that I've trained over the years in the United States have learned all the techniques, and it's something that you pass on. And what's ironic is, again, from our referral center, my fellows very commonly in their second year of fellowship will laugh that they can remove an implant from below the fascia with ease because they do it so often. But sometimes getting out those simple implants, they don't get as many of those because those aren't being referred to us. But people who have a lot of experience doing this with Nexplanon or with other implants are the people to start with, and you can build over time as each place then trains other people. It does take some time. And they have similar centers in the UK through the Faculty of Family Planning in the UK, and there's obviously centers in South Africa and other countries as well.
And then just one last question about the insertion or removal, and given that you certainly would have more experience than we do here in Canada at this point, one of the questions came from a physician: how painful is insertion or removal? And I think we have good post-marketing data on that from studies, but maybe you can comment on that before we move on.
Right. Oh, that's a great question. I think, first of all, the needle's a 16-gauge needle. For any of you that are very senior like me, and I'm saying that in a nice way to say old, but Norplant was a 10-gauge needle, to give you an idea. This is a 16-gauge needle, so it's the size of a large bore IV needle. You always place it with a little bit of local, and to be fair, the local hurts way more than the implant going in. It's very non-painful from it going in. You do wrap the arm to decrease bruising. I always tell patients, use whatever legal meds you want to for pain that you have, but it's usually not something that's very painful at all.
Great. All right. Well, that was great to have that insight. And now maybe what we'll talk a little bit more about is just kind of putting it into practice and counseling your patients on whether or not they might be a good candidate for using a long-acting method of reversible contraception versus using a short-acting method of reversible contraception. And I think, the first thing we always want to say that there's no one solution for every single patient. It's great to have options available to us, and certainly not only just for different patients, but for different periods in a single patient's life. So where would you kind of consider looking at one versus the other? And remembering that patients' reproductive needs and desires should be the basis for any family planning counseling. So there are kind of two key questions that can help identify a woman's current family planning goals. And the first one is, when do you want to become pregnant? And then the second one is, how important is it not to be pregnant until you are ready? And answers to those questions can really help inform tiered effectiveness counseling. And what exactly do I mean by that? Well, the WHO, this World Health Organization model of tiered effectiveness counseling, provides a visual perspective of pregnancy risk for the different forms of contraception. So you can see that the most effective methods result in less than 1 pregnancy per 100 women in 1 year, while the least effective methods result in about 30 pregnancies per 100 women in 1 year. So if we look in the top row, so in the top tier of this model, we can see that includes permanent methods of contraception like female sterilization and vasectomy, as well as the implants and intrauterine contraceptives. So considering that, if we look at our algorithms, because everybody likes algorithms, so let's look at an algorithm. And the first question is, okay, well, when do you want to be pregnant, if ever? And if they say less than a year, well, maybe that's a person who's better off with a short-acting reversible contraceptive. Now, if they say, well, not anytime soon, or at least a year from now, if not more, or maybe never, then you want to ask the question, well, how important is it for you not to get pregnant right now? They say, well, they're a bit of ambivalent. It's not really that important. Well, in that case, maybe it does make sense to consider a short-acting reversible contraceptive. Not that you couldn't still consider a long-acting reversible contraceptive, but maybe that the importance of that isn't quite as significant. However, they say it's really, really important for me not to get pregnant right now. Then maybe in that particular situation, you might want to counsel a bit more about long-acting reversible contraceptives, which would include the copper IUD, the levonorgestrel IUSs, or now the elonogestrel implant. Again, not that a short-acting reversible contraceptive may not be a good option for these women in this bottom corner, but if it's really, really important that they don't get pregnant, maybe it's best to use something where it's less adherence demanding, and we know that with typical use, the failure rates are lower than that we see with the short-acting reversible contraceptives. And sometimes we take our own biases as healthcare providers into a patient counseling scenario, and we assume that people may or may not want certain things. So we may assume that someone has no interest in having an implant, or they have no interest in having an intrauterine contraceptive, and they're doing perfectly well on what they're currently on. And what's interesting is this is from the Women's Choice Studies, the Choice Project. It was conducted in the United States, and there were over 9,200 women enrolled in this. And what they found is that when women actually received contraceptive counseling regarding all of the reversible contraceptive methods, and cost was taken out of the equation as an issue, Long-acting reversible contraceptive methods were chosen by 75% of women. So that's including the implant, the copper IUD, and the Elonogestrel intrauterine systems. So certainly it's not that women aren't open to that as a potential option. So we as healthcare providers, we need to kind of remove that medical barrier that we ourselves and our personal biases sometimes take into these counseling scenarios. So kind of bearing that in mind and kind of going over what we've already presented, I'm going to let Dr. Crennan take over at this point and talk a little bit more about putting this into clinical practice. So what do you actually do in the office when you're counseling patients on Nexplanon, so the new implant that we now have available in Canada?
Well, thank you, Amanda. And we're going to go through again, some things that for a second time, but it will underscore the importance of it. So I'm going to go over a little bit about efficacy, bleeding, and other side effects, and insertion and removal issues again. But I've seen some great questions, really good ones about differences between Depo-Provera and Nexplanon, for example. These are night and day. You know, keep in mind, Depo-Provera is giving a whopping dose of hormone. I mean, I even will explain this to patients because it's got to last for 3 months. So you're giving a Depo that's going to sit there and have to go away over time for 3 months, whereas the implant is there and just releasing a small, low amount every day. So this is not a replacement for Depo-Provera in the sense that you're going to feel the same. You just don't need to come in every 3 months. It's a much, much lower level of hormone. Any person who's getting taking a progestin-only method or using progestin-only method can get similar types of side effects, but the likelihood is lower, and that's the main issue. And we can't predict necessarily who's going to feel one way or another, but the amount of hormone that the person is exposed to on a daily basis is just significantly lower with the implant than with an injection. And, you know, when you have these methods around for a while and you get used to talking to people about it, you see that it really does change over time. To give you an idea that of LARC use, I think you were saying that in Canada in 2016 it was about 8 to 9%. In the US in 2016, we're at 18% LARC use, and 4% of that is implant users. And I will tell you that was an increase from 2014 to 2016 from 2% to 4%. Implant use, it doubled in 2 years. So it's really taking off and getting more and more popular as an option, I think, as more people get comfortable with it. So I'm going to move through these areas, and keep in mind that a lot of the issues around side effects really are the same kind of issues as bleeding when you come to think of what's going on and how do I treat it or address it. And I love that Amanda had a similar kind of chart. The chart on the left with the blue is actually the chart we use in our office, which is adapted from the World Health Organization chart. The one on the right is from the Centers for Disease Control in the US. And it's important to use these charts if you're not already doing so. This is evidence-based medicine. And you say, wow, how could counseling be evidence-based? In 2007, the World Health Organization actually published studies that looked at how do women best understand contraception? How do they best understand the trade-off? And actually what's funny is the CDC diagram that's used actually is one of the methods that was shown not to be as well understood by women. Too many words, too many things. Women just understand this trade-off, and their partners, I should say, so couples understand this trade-off concept where you tier the methods, where the lower ones are the third tier and the middle ones are a second tier and the top ones are a first or top tier. And this relates to effectiveness, but importantly, it doesn't mean that it's best for them. But if they focus first on effectiveness, there are first, second, and third tiers. And sometimes with patients, I'll just talk to them as these are the methods that are okay, these are the methods that are better, and then these are the methods that are the best. But it gives them a relative trade-off. And it's okay if somebody says, I feel more comfortable using pills. She just needs to understand that's a trade-off as compared to the IUD and implant, and that she feels that that's what's best for her. So LARC methods are the most effective reversible methods, but every woman isn't just interested in most effective. There has been a lot of work published lately about both reproductive justice and the concept of shared decision-making and coercion. I didn't want to put the word coercion on the slide, but it's really big in the US, and I don't know how it is in Canada right now. But contraceptive coercion is important to address on a personal level as well as in an institutional manner, that we have our own biases. There is a really great study that just came out that I didn't put the quotes in here that looked at providers and how would they feel if a woman came in 6 months after an implant or an IUD was placed saying, I want it removed. And it's amazing that up to a quarter of providers would refuse it because they feel that she didn't give it enough of a chance, where that's just wrong. We can place these products as long as patients feel comfortable saying, I want to remove it. It's not a failure if they want it removed. Our goal is not to have 100% continuation. Our goal is to have about 80 to 85% continuation in the first year. It's not for everybody, but 80 to 85% continuation. You realize birth control pills in the majority of the population has a 50% continuation rate at 1 year. So 80 to 85% with these LARC methods is amazing. It's a great method, great rate. So keep in mind that patients deserve the freedom not only to get the method, but to have it removed. Now, in counseling women about bleeding and other side effects, the reason this is important to understand is it's important to know if you counsel about these up front, you will be able to handle the problems more easily. Because the one thing that data has shown over and over again is that when a woman comes in who is frustrated with her implant and says, I can't take the bleeding, I don't like how I feel, this thing sucks and I want it out, there's nothing you can say, very little you can do. Even if she accepts treatment from you and feels better, she'll still come back with a high probability of wanting it out. So you're too late in the game. So your counseling has to really address these issues up front. Be very forthright and say, this implant causes irregular bleeding, but it's something that we can take care of if you find it problematic, right? Not everybody does, but for those that do, we can help your bleeding. Some people do experience some mood swings. Some people do experience a little weight gain, usually not different than the general population. If you find you're having a problem, come in and talk to me. There's something we can do. And really what people are saying whenever they have any of these issues is it's just the progestin effect. The benefit of this method is it's a really, really super low dose of hormone on a daily basis, right? So that you're really talking about something that's multiple hundredfolds or multiple times lower than an oral contraceptive. So we can provide an oral contraceptive at the same time if she feels she needs it. And we're going to get into some of that data to give you an idea of how to handle these side effects. So one of the big questions always has been, how do we discuss bleeding? And my colleague, Diana Mansour, along with me and some of our other colleagues, have published a lot of looking at this data and counseling tips. Somebody asked earlier when it was brought up about favorable and unfavorable, what are those patterns? Well, that data comes from WHO criteria that was established decades ago that looks in bleeding in 3-month intervals and says, okay, what's a favorable pattern? Usually a favorable pattern is when there's no bleeding or the bleeding is infrequent. And unfavorable patterns are irregular, heavy, prolonged. So that's kind of how we can define the bleeding patterns, right? And going back to some data that was put up earlier about the types of bleeding patterns, let's go through this a little in detail. The first thing I tell patients is bleeding is unpredictable. It's unpredictably unpredictable. And you have to be prepared to accept that you don't know exactly what your bleeding pattern is going to be. For most women, the bleeding is light. And that's a really key thing to understand. It's not really, you can see as you look below, there's very few women, it doesn't even make the chart, that have heavy bleeding. So for most women, it's light. It just tends to be irregularly irregular. All right. So that has to be something you can accept. And I just told you that 4% of US women, which is double what it was 2 years prior, use the implant. So it's not something that women say, oh, I absolutely can't use this. This is horrible. 1% of people use it. It's continuing to increase in utilization. Now, this idea of what is the bleeding pattern in each percentage of 90-day intervals, this doesn't mean that 22% of women have amenorrhea and they stay amenorrheic. This is the percentage of women who report this in a single 90-day interval over 2 years, and their bleeding pattern may change from interval to interval. We're used to the hormonal IUD, like the Mirena in Canada, where a woman may become amenorrheic and then tends to stay amenorrheic, or just say, I have amenorrhea or maybe a little spotting, and that's it. I don't have much of anything. Women with the implant may be amenorrheic in 1 3-month interval and then have irregular bleeding in the next one, right? So you have to prepare them that it's irregularly irregular and that there are going to be some women that have persistent amenorrhea, but that's going to be a very low rate. So if you promise women that there's a 20% chance they're going to be amenorrheic, that's false, right? What you want to explain to them is primarily it's just irregularly irregular, but it tends to be very light, and most women tolerate it, all right? Now, we can also look at the pattern. I explained to women that most women, about 2/3, it's just easy to remember, 2/3 will have a favorable pattern or something that they can put up with really well in their first 3 months, and about 1/3 will have an unfavorable. If you want to use 60-40, that's fine. But there's really good data that we just published last year looking at all the original trial data that shows that if it's favorable initially, all right, that there's an 80% chance that the next 3 months will also be favorable. Right? And if that first interval is favorable, there's about a 60% chance it'll stay favorable the entire year, right? So I always tell people your first 3 months kind of tells you how it's going to be. If it's a really good, tolerable 3 months, then there's a really, really high chance it'll stay that way and life will be good. If it isn't so good, then there's about a 50-50 chance. So if you look at the data in the middle of the slide, so for people that have an initial favorable pattern, discontinuation rates for bleeding is 4% at 12 months and 6% at 24 months. Keep in mind the overall discontinuation rate at 24 months for bleeding is about 13%. So those with favorable patterns have a much, much lower rate than the population as a whole. But if it's unfavorable initially, then only about 50-50 chance you'll have favorable the next time, and there's about a 50% chance it'll stay unfavorable. And the discontinuation rates for bleeding is 13% at 12 months and 21% at 24 months. So you can see how bleeding has the type of bleeding she experiences has an impact on discontinuation, and also that initial 3 months will tell her how it goes. So that's why it's important. If she has intolerable bleeding in the first 3 months and she knows it's only 50-50, and she says, I want it out, that we don't get back to this reproductive justice issue and say, I'd be happy to take it out. The other thing that's important is in any 3-month interval, if the pattern is favorable, there's an 80% chance the next one will be favorable. Even if you go out at a year and a half or so, if she had said, boy, I really had a good 3 months, 80% chance that next 3 months will be good. So people who are favorable tend to stay favorable. And this is another way of looking at it. The green is favorable bleeding, and this is over the different 90-day intervals. And that you can see those that have a really good first interval, they tend to stay favorable, all right? And in the unfavorable group, you can see it's about 50-50, all right? That same concept. So, and this is how it plays out for discontinuation, that about 13% of women in the US over 2 years, and about the same in European trials, will discontinue for bleeding in 2 years, 13%. And I know there was a little bit lower data before. When you include women that are in Asian countries, you get a lower rate. So China, Indonesia, Thailand. So North American and European data is about 13%. Compare that to the discontinuation rate for irregular bleeding with the lower dose levonorgestrel IUDs, and with the 52 milligram IUD, you can see there's much more irregular bleeding and much more discontinuation, right? So it's just important to be upfront with your patient about it. If bleeding is a huge, huge concern for her and she's not going to tolerate irregular bleeding, this isn't the method for her, right? So just be aware of it, and it's okay, right? So what do? Right? If you've talked to your patient ahead of time and said, look, if you find that the bleeding is irregular and bothersome, don't get this out. This is the greatest method at preventing pregnancy. You've already gone through getting it implanted. I can help you. What can you do? Well, there's lots of different things that have been tried. To be fair, the best data that's out there is in combined oral contraceptives. There are women who are going to have a contraindication to combined oral contraceptives, and tamoxifen may be of benefit to them. So I just want to go through a little data, and using the two together is fine and safe. Again, the amount of hormone with the implant's incredibly low. You add the birth control pill to it, it's really just like taking the birth control pill, and that's what the studies bear out. So just really quickly, if a woman's treated with a combined pill who has irregular bleeding, you can see on average the bleeding stops in about 5 days, and in virtually everybody, in 88% of women. So it's very quick at getting that bleeding stopped, all right, compared to placebo, where only about a third of women will stop, because there's going to be a natural on-off, right? The problem is that the majority of women have their bleeding recur within 10 days of stopping it. So if you tell a woman, well, just use a birth control pill for a week and you'll feel better, or just use a birth control pill for 1 month and you'll feel better, that's true, but her irregular bleeding may come back. So there are other studies, that look at using it for longer. There's a study we did for 3 months and another one we did for 6 months. Now, the 6-month study was a little different. We were actually looking at using the two together from the get-go, changing the way we were addressing women and saying, instead of saying you can only use one method or another, if you're a birth control pill user, what about using the implant as a backup? All right. Now, this is a novel idea, and we're in the middle right now of a multi-center study that's looking at this further. But this study gave us information out to 6 months of use. So we had subjects, almost all the subjects continued for 6 months of use. We had some new starters and some current users, and you can see there's lots of different bleeding patterns. But the key is nobody discontinued in the first 6 months, in that 6 months of use for bleeding. Nobody. Unheard of with the implant. Right? And even the few people that had what would be considered an unfavorable pattern, it wasn't something that was so bad for them because the bleeding was still light and they felt they could continue. Not everybody has amenorrhea. Not everybody has regular bleeding. Most people have infrequent bleeding. But you can see the key for this is I wanted you to understand when you use the two together for 6 months, it's safe. People don't have more side effects. I'm not going to show that data, but that you can see any bleeding pattern, but that people tolerate it. Now, what about your patients who have a contraindication to estrogen? There was a paper that was just published by my colleagues in Portland, Oregon, at Oregon Health and Science University, where they gave tamoxifen 10 milligrams a day for 7 days for anybody that had bleeding that lasted for more than 3 days. Now, this wasn't a study of women who had bothersome bleeding, and that's what's key. So we don't know how well this would work as a treatment for people who say, my bleeding sucks, can you do something for it? What they did find was that there were more days of amenorrhea when women were given tamoxifen as compared to placebo. This is the probability of continued amenorrhea. So you can see it was best in women who received tamoxifen. And then those in the placebo group who then later got tamoxifen. But importantly, there was no difference in the discontinuation rates. And this gets back to people having bothersome things for them. And I really think it's about how you counsel people up front. All right. So for bleeding treatment with oral contraceptives, the key is it helps bothersome bleeding. It'll stop bleeding for most women. It'll improve their satisfaction, but it doesn't change future bleeding patterns. And there's a high continuation even with 6 months of use. So, and we'll have more data for you with a year, hopefully coming up soon. Tamoxifen is an option for women with estrogen contraindications. There is more amenorrhea, but there's also, and I didn't show you that data in lieu of time, but there's also more side effects, and that's why women discontinued, because the tamoxifen did cause some side effects, and that's why there was no change in the discontinuation rate. The key is to intervene before people are frustrated, all right? To talk to them at the time of placement, before placement, about these things that may happen, and present yourself as a resource to say, please contact me. I'm happy to help you with these issues. All right. Then lastly, I'm just going to go over insertion and removal again. So how do you handle those problems and discussing it with them up front? All right. Be realistic about the possible rare deep implant placement. Assure that you can provide care or referral. Don't hide this from them. I will tell everybody about 1 in a million women will have an implant placed so deeply that it'll go into their lungs. But again, that's 1 in a million. That's lower than their risk of dying in a car accident. Sometimes it helps to give people who are a little scared some perspective. Provide confidence that you will provide removal anytime that they want it, because you can go online on YouTube and you will see that patients will self-remove it. Place some ice there, take a razor blade, make it cut. If it's superficial and you can get it out easily, so can they. So make sure you provide yourself as a resource and discuss bleeding as a reality and say, look, if it's frustrating to you, come in. Same thing with side effects, and side effects are very much the same. When people are feeling side effects, oral contraceptives, as long as they're not contraindicated, are really one of the best ways to help them feel a little bit better. And I do have quite a few patients who are just using both, because the reality is that oral contraceptive is a tier 2 method. They really, really, really don't want to be pregnant, but they really, really are not great at taking their pills. So if they're on both and they mess up on their pill, it doesn't matter. They've got the implant in place. And then for performing removal, since this will be new for many of you, know your limits. Go through the training, understand how to use your knife, how to use a hemostat to get the implant, but know your limits. no removal really should ideally take more than a few minutes once you've gotten a few under your belt. Set an upper limit. Give yourself 10, 15 minutes when you start. But once you've done a few, it really shouldn't take more than a few minutes. And if it is, and you're really having trouble even accessing the implant, stop. Send the patient to somebody who has more experience, and it's okay. And even to tell the patient that you have experience, but that in this situation, it's just too difficult. And rather than make a big incision in her arm or cause her harm, you'd rather she then go see someone with more experience. And just be upfront with her. And it works really, really well. And then know your referral sources. Know where you can send her. All right. Incorporating the implant into your practice. If you've never placed implants in your practice before, prepare your staff. Not only put yourself through training, put your staff through training. Explain to them what you're going to do. Make a kit of the supplies that you're going to need. Don't just try to pull together the when somebody comes in for removal, I need a knife and I need some 4x4s and I need some alcohol and I need some betadine. Make a list for your staff. Have your staff say, we're gonna put together a kit, so you go in the room with all your supplies. And the same thing at the time of insertion. Put it all together. When you give your local, you're going to give a little bit of lidocaine, make a wheel, and then a little bit on the skin. It only takes a couple of cc's, but use local with epinephrine. Lidocaine with epinephrine. If that's not in the video, but I'll tell you here, it just makes the bleeding light, it makes the bruising less. And the same thing when you do a removal. Use lidocaine with epinephrine, because that way you can see your field. But get everything together ahead of time. All right. And I think, I forgot I put that there. And then as time goes by, as you get more proficient, you'll learn that because this implant is so easily palpable, when you're cutting on the implant to kind of make your initial incision and just free up the tip, you'll see you don't necessarily even need to use a hemostat. Start with that if it's new for you. But the implant, when placed well, will literally just pop out as you see here. One of the best innovators of the pop-out technique is one of my former fellows, Helen Pymar, who's in Winnipeg, a great resource, and published the largest series of pop-out techniques of implants ever published. So you can learn it too. And I think I'll stop there. And I think there's lots of great questions, and I think we can try to go through them. Can we unmute Amanda?
Thanks. That was great. So thanks so much for giving us all that kind of inside scoop on the real world working with the implant. I think some of the questions that were popping up, maybe you could answer them, were the use of, and I think you did touch on a little bit, bleeding's always an issue when we're talking about methods of contraception. And some people had asked about, estrogen, short courses of esterase as a possibility. There were some other things coming up. So I think, do you have kind of a little kind of order that you'll often try to go through if someone's willing to try a few things and wait a little bit?
Right. No, that's a great question. So Premarin, esterase, those are minuscule doses of estrogen. I mean, if it helps, it's the fact that she would have helped anyway. I mean, you really need to, the lining is telling you it's just really thin. You need to build it up. You need to boost it. Physiologically, those doses aren't going to do it when you have such a strong progestin, making it atrophic or hypertrophic. So we usually will start with a 30 microgram levonorgestrel pill. That's just typically what we've used. You can try a 20 microgram pill if you want. I wouldn't go any lower than that. The lining really needs a boost. And you'll see all the studies that have been published, the 3 studies that have been published, all use that same 30 microgram pill. Let's see, we can go through some of these. Do you want me to start at the beginning, or what would you?
Well, maybe what we'll do, we'll kind of go on, because I think there are a few other questions too, but maybe you can answer some of those as we get into the rest of the chat. I think one of the attendees really said congratulations on pointing out the issue about the contraception coercion and the fact that we want to avoid, while we're in our enthusiasm to make sure someone's using a method of contraception, an effective method of contraception, that we want to avoid being coercive and how we do that, not just how we maybe put it in, but how we're willing to take it out as well. And the SOGC actually published a committee opinion on that recently. It's on our website about contraceptive coercion and the importance of that, because unfortunately we do have a history of that in our country. So thank you for bringing that up. That was a really important point.
I think we all do have that issue historically. Someone asked a good question about why are ovarian cysts so common, because Dr. Black went through the ovarian cyst question. And that really has to do with how the study was done, because they were looking for them and measuring them, and they qualified a cyst above a certain dimension. I will tell you, this is one of the best treatments for patients that have recurrent ovarian cysts. It really shuts the ovary down really, really well. And you rarely see anybody with cysts at all until you get out past the second year. So it's very good for those patients as well. Let's see, we took that.
I think there were a lot of questions too about progestin, the difference in progestin levels if we're comparing the implant to, say, Kyleena or Mirena, or the progestin-only pill, or Depo-Provera. And I think that one of the things is the levels are actually not that high. Are you able to comment on that?
Well, these are still a little bit higher than you're going to get with Elonogestrel IUD. So when you're always better off. And to be fair, once you get down to a Elonogestrel IUD, the difference in the levels between Kyleena and Mirena, even though they're measurable, are of no significance. There's a randomized trial, really well-done randomized trial to Europe that showed that the side effect patterns, the systemic side effect patterns for the two products were exactly the same. So you're really just talking about minuscule levels between, when you get down to Kyleena and Mirena, and there's really no difference from a systemic standpoint as far as its impact. With the implant, it's a different progestin. It's still the same family of progestins, but it's different, and it's a little higher level because it's still systemic. So people are going to potentially have slightly more side effects because you're dealing with systemic hormones. But then compared to, as I mentioned earlier, Depo-Provera, that's a huge amount. You know, you're talking differences, multifold differences, and delivery differences. I think one of the key things I get when I talk to patients and they're worried about hormones is I try to stress to them there's two things. One is what is the hormone, but the second is how it's delivered. Right? People will say all the time, well, I took birth control pills, I didn't do well on them, I can't use hormones. And I try to explain, well, an IUD, an implant, very different. Even a ring, much lower levels than an oral contraceptive. But it's explaining that and taking the time to explain it. Somebody asked earlier, too, about the bleeding pattern differences between the different progestin-only methods. Interestingly, for virtually all of them over the first 3 months or so, whether it's a pill, an implant, an IUD, or an injection, there's going to be irregular bleeding, you know, and it's pretty much not that much different when you look at the statistics. They start to differentiate out after the first 3 months. The hormonal IUDs, they'll start to decrease. Depo-Provera, it actually starts to decrease. The implant, it's variable. It doesn't really start to decrease. It still stays that same irregular. The key in your counseling is to stress the fact that whatever it is, it tends to be light, and most women tolerate it very well. And if it's bothersome for you, you'll know in the first 3 months, and I can help you if it's really bothersome. I also will line people up, especially those who don't have a contraindication to pills, with the idea of using pills with it. I'll line that up front because they'll come back and then you're thinking, well, why are you making me use 2 birth control methods? And you're trying to stress. It's no different than women who actually, we had a patient the other day where we said, you know, we talk about 2 birth control methods all the time when we talk to you about using your oral contraceptive to prevent pregnancy, but condoms to prevent STDs. Right? You use them for different reasons. So for women that are using an implant to prevent pregnancy, they may be using a birth control pill to make their bleeding tolerable, right? So because the efficacy when you go from the implant to the pill, it's dramatically different, just like the efficacy of the pill to the condom is dramatically different. So it's just changing our thinking. We've spent so much time with those charts talking people into which one method are you going to use, instead of saying, you know what, these are contraceptives, but 40% of the time people use these methods exclusively for non-contraceptive reasons. So it's okay to talk about using them for non-contraceptive reasons while you're using the implant for contraception.
Yeah, and I think that is a nice segue into a question that we've got from a couple of people about some of the what we consider off-label indications. For example, using it as hormone therapy. There's the progestin component of hormone therapy. Someone asked about it if there was any data for treatment of endometrial hyperplasia. Maybe I don't know if you want to comment on that in clinical practice and also knowing what's out there in the literature.
If it's a hyperplasia without atypia, which is a benign condition, you can use progestin in any way you want, right? So it would work, obviously. If you're dealing with somebody with atypia, then you need to go with where there's data, because there's a 20% chance there's cancer there. The only data that exists about a conservative management is with a 52 milligram levonorgestrel IUD. It wouldn't surprise me if it may work, but I wouldn't fool around in somebody with atypia. There is data that's published on its use for endometriosis. Again, it's really good at shutting down the ovary. Because women may spot from the uterus, they could theoretically spot or bleed from implants as well. But generally, it does tend to be used really well. I use it very commonly in endometriosis as a combination. Like I'll use it in conjunction with a birth control pill to really keep things quiescent. But there isn't a ton of data, but it's something that could be used and would be beneficial. It definitely is really good for dysmenorrhea. For patient, I have patients who have dysmenorrhea that don't want an IUD, are willing to put up with irregular bleeding, and they are incredibly happy because whatever bleeding they have is significantly less painful.
And what about, and I think you spoke to this too, but the bleeding profile that we can expect, or maybe aren't sure what to expect with this, because people are asking, well, what about using it in the management of abnormal uterine bleeding in a perimenopausal women? And, when would you use this versus levonorgestrel IUS? And I'm imagining this wouldn't necessarily be your go-to if you're trying to manage abnormal uterine bleeding, or if that was one of the issues that was presenting. So thoughts on that and what you've had and seen in practice?
So as long as you have your biopsy that shows there's nothing that has atypia or cancer, obviously then you can proceed with medical management. For somebody whose primary complaint is heavy flow, then this would be something that might be reasonable. But for the person who says my bleeding's irregular, unpredictable, I don't like it, this is not going to be helpful. Mirena is good because you can tell them, look, for the first few months it may be that way, but it's going to lighten significantly. Remember with Mirena and its counterparts in other parts of the world that have the same amount of hormone, that with it at 9 months, not even a full year, at 9 months, almost 90% of women have either no bleeding, 1 or 2 days of spotting, or light bleeding. That's it. So it continues to get lighter and lighter after the first 3 months goes by. Whereas this is, if their main complaint is irregularity, unpredictability, this is just going to go right along with it.
Now, on the other hand, if it reliably suppresses ovulation, then it should be a useful adjunct if you're looking at trying to treat premenstrual syndrome. Do you find that, or have you ever used it for that, or what's your experience with that?
For people that have ovulation-related symptoms, it is very useful, but you're also trading off for the potential for others, right? So sometimes it's a matter of going through what they've used before. Are continuous COCs a better option where she can control it a little better, where there's a balance of the hormones? Because at least in my experience, people who have cyclic symptoms tend to do better when you provide them with both hormones, but that's just my experience. You go with what your experience is, because the other thing is everybody's population is different. The people you see in your community may be different than the people I see in my community. So yes, it could be helpful, but it wouldn't necessarily be my first go-to for somebody who has cyclic symptoms. Again, it's depending on what they've tried before and what they're comfortable with.
Right. Well, I think what I might do, there's just a few things we just want to summarize. It might answer some of the other questions that are coming in. If we have a couple of minutes left at the end, maybe we can get to those, or maybe you can answer some of those as I summarize a few points here. So just again, quick summary. The Elonogestrel implants is a highly effective, long-acting reversible contraceptive. So it's approved for up to 3 years, but there's been evidence showing that it's probably effective for longer than that. It has an excellent safety and side effect profile, and there is a rapid return to baseline fertility. Complications of insertion and removal are rare, but again, as Dr. Kennan said, it's important to know your limits as a provider and when to phone a friend and ask for help. And the importance of counseling about bleeding patterns, that's really, really essential. So some of the questions that were coming in about, well, do I need to get trained for this? And how do I get trained for this in Canada? And what about these centers of excellence? And how do we find out about them in Canada? And there is a Nexplanon clinical training program. And I've posted the web link for that in the question and answers session in the box there. And that's elonogestrelimplantraining.ca. And then you can also view the insertion and removal videos at nexplanonvideos.com, and that's where Dr. Crennan makes a guest appearance and in the removal video. The SOGC will also be is in the process of developing an Elonogestrel subdermal clinical preceptorship program. So that'll include the clinical training, as well as provide you with some checklists for insertions and removals, as well as a standard consent form if you wanted to use that or adapt that for your own practice. The other contact that you can have is Merck Canada, and certainly not everyone is probably familiar with their Merck reps, and sometimes they change. So the number for Merck Canada, I posted it there, and they can provide you with information on certified inserters or removers in your area. If you don't want to be inserter remover, you want to counsel and you refer patients, but you don't want to do yourself, then you can be at least aware of who you can refer to. They can also give you information on the centers of experience that are being established in Canada. And lastly, we didn't really talk about it, but in some instances, Elonogestrel levels may be ordered to confirm the presence of the implant, not a location of the implant, but the presence of an implant. But that's not something you can do by just sending them to the local lab. It's something that you would have to call Merck for, and they would help assist you in getting those Elonogestrel levels performed. So hopefully that answers your question about the training, and is it required? I would say I would certainly strongly suggest it, and I think Mitch, you would agree that it's a good idea to do the training before doing it. I know someone had said they'd taken them out with a punch biopsy before and it came out easily, but I don't know that that's something we would want to be suggesting regularly. I think you would want to go through the training and see. So we have a standardized technique to this and hopefully avoid getting ourselves into any trouble. So I think maybe we have time for one or two more questions there. Mitch, did you have a chance to look at any to see if there was one that you wanted to address?
I did, and Amanda, thank you for actually leading everybody through this. So you were great. Just really quickly, somebody asked, are there any studies going on in obese women to extend the use? And there actually is a very, very large study that's about to start to provide us with the largest amount of clinical data through 5 years of use in both obese and non-obese women. So stay tuned. That'll probably be about 5 years till the data is out. Somebody asked about why it's in the upper extremity versus the lower, and that has to do with access and also the potential for harm. The inner arm is an area that is the area of the body that's the least jarred area, the least hit area. It's recommended that you place the implant in the non-dominant arm just because it's used less, but to be fair, you can ask the patient where does she want it. And it can truthfully be placed anywhere in the subcutaneous tissue and it will work. There are some case reports of placing it over the scapula in patients with psychiatric disorders that would dig at it if it was inside their arm. So the reality is it can be placed anywhere, just the inner part of the non-dominant arm is where it tends to be placed because it has the lowest risk of trauma. A lot of questions about those specialized centers, so I would say contact Dr. Black. And then somebody asked why bone mineral density is an issue for Depo-Provera and not Nexplanon, and it really does have to do with the hormone levels. Remember I said that Depo-Provera is just a very large whopping dose, and in a one-size-fits-all type of drug, so you end up with a lot of potential impact. I could spend an hour just talking to you about bone mineral density, and to be fair, I'll sum it up in one sentence of that it's a joke. It doesn't have any clinical relevance, but so don't worry about it anyway. And anything else that you see, Amanda, that you think would be important?
No, I think there were some questions that came up about costs and is it available in Canada, and I think you answered that, but in the chat. But just to let people know that the wholesale cost is $285 in Canada, that it is available in pharmacies now, so you could order it or give a patient a prescription for it, and pharmacy, if they don't have it, they can order it in, so patient doesn't have to order it themselves. As far as coverage, most private payers actually are paying that already, depending on what they're already covering for contraception, but most private payers, it is covered under those plans. The other formularies, provincial formularies, in Ontario works, and other in Quebec, the provincial formulas, that they tend to lag behind the private payers. So those are all under review at the moment, and hopefully we see progress with that. And similarly with OHIP Plus in Ontario, if you're in Ontario, it's not covered by that yet, but that would be under review. So, lots of questions about the logistics of it. So things are in progress, and we're getting there, definitely. Great. So I think at that point, we've already done that. So I'd like to thank everyone for coming tonight and for everyone's enthusiasm, asking so many amazing questions. It's great. It just shows that you're engaged and you're excited about having a new option. And, we've had great success with the Elonogestrel IUS. It's been 20 years now, so we're at the 20-year mark. So it's nice to have something else that we can offer as well in addition to that. So certainly I'd like to also thank Dr. Crennan, because having someone who has that experience in the trenches and who's able to talk to us and answer our questions is absolutely invaluable. It makes a huge difference, because all the clinical trials can say one thing, but it doesn't necessarily help us when we've got the patient in our office in front of us who's got something going on, and how do we deal with it? So it's a huge help for us. So thank you so much for attending this evening.
Thank you for including me, and thank you, Amanda, for all the hard work you put in and the great detail you provided.
Great. So with that, I think that unless, Dr. Crennan, do you have any last-minute words of wisdom that you'd like to impart on us before we say goodnight to everyone?
Good insertion technique.
Okay.
And
that's
wear
right.
a mask.
And that's
wear a mask.
Right.
Please remind all of us that we need to do better at wearing masks.
Yeah. All right. So once again, everyone, thank you very much for attending this evening, and we wish you all a good night. And depending where you are in the country this evening, a good night, good supper, and thanks again for coming. Take care.